Hello, thanks for listening to the Total Knee Tips and Pearls podcast. This is Adam Rosen, your host. I'm a fellowship-trained orthopedic surgeon who specializes in joint replacement. In these episodes, I'm going to share with you a lot of my tips and tricks and review classic articles and current implant designs. Thanks for tuning in, and on with the show. Hello, welcome back. This is Adam Rosen, and you're listening to the Total Knee Tips and Pearls podcast, where in this season we're going over different classifications, common classifications that you're going to know about, learn about, get pimped about when you're on your orthopedic rotation. So if you're just tuning in for the first episode, again, briefly, my name's Adam Rosen. I'm a fellowship-trained orthopedic surgeon, been in practice over 15 years. And this was one of those things I had always wanted to do, was actually start a podcast just to share some of my information, my knowledge with people outside of those individuals that I directly interacted with. So the podcast first season that you heard, hopefully you've listened to it already, was an outline that I had developed for a while. I wasn't sure how to get it out there. So I've had some people ask, well, how did you get started with a podcast? What did you do? I looked online for a few different places and found Buzzsprout, which I thought was very interesting, super easy to use. I was actually super impressed because as I started looking into different hosting sites, I had finally decided on Buzzsprout, signed up, set everything up, and had some questions that just sent into the info sort of email and got a response back. Sincerely, Priscilla. And I wasn't curious, or I was curious, is that a real person? Is it just a bot, sending an email back? And she assured me, nope, she was a real person, and we responded back and forth, and she was great at answering questions, and they've been that way ever since. So it made my job quite easy because I was able to just, create the files, edit it, upload it, and then it is a seamless transition. So if you're interested, in podcasts, check out Buzzsprout. I think they make this transition from someone that knows nothing about how to podcast to making it pretty easy to use on a regular basis. Now, on today's episode, what I want to get into, keeping with the theme of classifications, we're actually going to talk about two today, specifically with regards to hip fractures. And probably one of the most common and classic classifications that we talk about is the Garden classification, but it sort of goes against the things that I've talked about before, where we want a classification that is reproducible. And this is one that's been proven over and over again to not be super accurate, when you have people classify it. And the important thing that I want to do is in this specific instance is talk to you not only about the specifics of knowing the classification, because a lot of people mess it up and get it wrong, but also what I do in practice and how do I use the x-ray and the classification to make a decision on how I'm going to treat someone. So Garden first published this. This was in the JBJS British 1961. So that's when this article came out, and it was entitled Low Angle Fixation in Fractures of the Femoral Neck. And when he did this, it's a really interesting article because if you go back and read just in the introduction, he talks about these things that I'm sure most of you have never seen, or maybe you saw it on an x-ray and someone's like, what is that? And the attending, if they were old enough, said, oh, it's this or that. So he talks about the Smith-Peet nail and the Jewett nail and the Kushner nail. And it goes into all these, different things. But again, this was a long time ago. I mean, we're talking 80 years ago, when he published this article. So obviously things have changed. So let's jump into his classification. By now, hopefully, there's 4 types, 1, 2, 3, 4. And if you look at 1 and 2, you're supposed to be non-displaced fracture, and 3 and 4 are your displaced fractures. Now, let's talk about the type 1, just because that is, I think, the one where people mess up the most. So, he's talking about subcapital fractures, and in his original article, he described it as stage 1. Commonly, about people talking about type 1 Garden, but he described it as stage 1. Now, this is an incomplete fracture. So this means that the fracture is not complete. So if you see any break in the inferior cortex, it is not, by definition, a stage 1. And that is a big mistake a lot of people make because they've been taught and they memorize valgus impacted. So you see a 2, which is complete. The inferior and superior aspect of the neck are broken, but the head is still in valgus. Yes, the head is in valgus, but it is not a stage 1 because it's an incomplete fracture. And the other things you'll notice or pick up on shortening, right? If the inferior neck is intact, there should be minimal shortening. It's just the top is hinged. And if it's type 2, it's complete. It may be in varus, it may be neutral, it may be impacted, it may be in valgus, but it's complete. It went through the superior aspect of the neck and the inferior aspect of the neck on that AP X-ray. So just be aware of that major difference, because I see a lot of people will call a 2, which is completely fractured through the neck but in valgus, a type 1. But valgus impacted by definition means that it is incomplete. The inferior cortex is intact. Now, stage 3, or what a lot of people call type 3, is a complete fracture, but with partial displacement versus the non-displaced fracture of the type 2. And type 4, stage 4, is a complete fracture with fully displaced. I mean, these are the obvious ones where, the neck's like sitting above the acetabulum. And those are sort of no-brainers. Now, what is interesting, though, from a historical standpoint is when he treated all these with Jewett nails, he went on and recommended full weight bearing. Encouraged when possible. So even back then, 80 years ago, they were putting a nail in full weight bearing, but also these patients spent weeks in the hospital. And back then there was an issue that they saw with healing. So even when they tried fixing these, this was after, and again, they talked about fully reducing the fracture. It's very, very different. So these are fully reduced fractures treated with a Kushner nail. They only found that 50% of the stage 4s or type 4s healed. Where now typically you're treating that with arthroplasty, unless it's someone super young and where you're trying to save the neck. And then, AVN is the thing that we talk about. Even in his article, he talked about how in 1958, and the French, and I always kind of bugger up the pronunciation of his name, but Dubonnier noted 50% AVN rates in subcap fractures. We still know that those rates are high, and not as high for all of those stages. But when the vascular supply is disrupted with those higher stage 3s and 4s, that if you did try to fix those versus going to an arthroplasty, that your risks of AVN are higher. Now, the interesting thing, actually, now that we're talking about it, I actually didn't look it up, but it's something that I do on a regular basis, is the idea of this sort of intra-articular compartment syndrome and, large hematoma in the joint. So one of the things that I do on a regular basis is if I am treating one of these with cannulated screw fixation, versus arthroplasty, a lot of times under guidance with the fluoro, putting a needle in the joint, decompressing the joint. Sometimes I get nothing. Sometimes a drop or two of very thick, hematoma blood. But, on occasion, I pulled out a good 10, 15 cc's in the hopes that, that decompresses the joint, improves the vascularity to the femoral head, and may potentially decrease, the rates of AVN. But I don't have an article to quote you on that now. Now, the other classification, though, that I want to talk about, because sometimes they get used together, and I think they're useful in some ways, is the Pauwels Classification. This was first described in 1935. And again, sometimes people mess this up. So, he talked about, Pauwels 1, Pauwels 2, Pauwels 3, and this is on an AP X-ray. The angle, what we're talking about, is from the horizontal. So if you're kind of, trying to remember vertical, horizontal, just remember that the Pauwels 3 is a more vertical fracture, and a Pauwels 1 is a less vertical fracture. So a Pauwels 1 is a fracture line off the horizontal up to 30 degrees. 2 is 30 to 50 degrees, that fracture line in relation to a line drawn across the horizontal. And a Pauwels 3, the fracture line is vertical, so it's greater than 50 degrees from the horizontal. These are the most unstable, and these are the ones with the highest risk of AVN. So when you're looking at these, you may sometimes take those, in conjunction, that, maybe you have, Garden 1, 2, and you're thinking, should we pin these? But there's also a Pauwels 3. Your chance of failing is probably a lot greater. Whereas, if you have a Garden 1, 2, and it's Pauwels 1, maybe the risk of healing is better. Now, the other thing too, just as it's one of those things, I think it's worthwhile knowing. It may be a pin question that you get asked. I find a lot of the residents sometimes haven't heard of this yet, but be aware of something called Ward's triangle. It's something that we will also talk about in hip fractures, especially with osteoporosis. So this is this triangular area in the proximal femur that is made up of these lines of the primary and secondary compression and tensile lines. This was actually first described in 1838, so a long, long time ago. But look that one up. That's a good one for you to know from an anatomic radiographic extent. So that being said, what do I do? So, this becomes the big question. I think sometimes things are easy, right? You got someone with arthritis with a completely displaced femoral neck fracture and otherwise healthy community ambulator. Pretty much most places in the world now are going to be doing a total hip replacement. I think the harder part, though, are these incompletes. Like, do I pin it? Do I not pin it? So in a true Garden 1, in a true valgus impacted, in a true hip fracture, which is incomplete and the inferior cortex is intact. Those are the ones where I'm typically pinning. I try to aim, for an inverted triangle. And for the most part, you're looking at these patients and saying, healthy, not healthy, stabilized fracture, protect the neck, less invasive. In my opinion, definitely less risk than an arthroplasty, and give them a good chance of healing. And then if it fails, it's something that you can always convert. Now, I think the harder part is, do you pin grade 2 or stage 2s? And the answer is sometimes. Who are they? So, I kind of break this down into two main groups. So I have some of these stage 2 fractures that, patient hits the floor, can't bear weight, presents, via ambulance to the ER, inability to bear weight, in pain. And it's a 2, but they're painful, they can't bear weight. Now, the other thing that we didn't really talk about also, though, which is also important, is the lateral. Something, again, one view is no view. So something may look great on the AP and be completely off on the lateral. So, with these 2s, you really have to kind of differentiate. Is it a 2? Is it a 3? Just because it looks lined up on the AP doesn't mean that it's truly lined up on the lateral. But we're talking about a true stage 2 where it's complete, but it's really non-displaced, it's impacted. If that person can't walk, can't bear weight, in my hands, in my opinion, that's the person I'm talking to, but I'm offering them arthroplasty. And, younger, active individual, arthritis, total. If they're, older, sedentary, lower demand, may already be on a cane or walker, that's someone that I may use a hemi on. And have that full discussion on what are the pros and cons, risks and benefits of both. Now, there are the people, though, and I get this, just on call last time, I had 2 patients like this. Phone call from the primary. My patient fell 2 or 3 weeks ago, had pain for a couple weeks, presented to my office. I sent it for x-ray 3 days ago. I just got the report back. It says they have a hip fracture. That is the one that, to me, has proven that it is inherently stable. This person's been walking on it for 2 or 3 weeks. So, to me, in my opinion, that's a big stretch to then go in and take the head out and go to a total. Because obviously this is a community ambulator. I'm not going to do a hemi on this person. I'm going to do a total. And you have the discussion with them. Hey, we can go in and do a total. This is, the hip replacement versus, this is the pin. If it fails, if you do develop AVN, if it collapses, if it doesn't heal, and also talk to them about shortening. If you develop significant collapse and shortening, and that's significant along with pain, then a conversion to a total hip replacement. And 99% of the time, patients are going to say, yeah, pins, give me pins and let this thing heal, and I'll worry about it later down the road. Now, 3s and 4s, hemi versus total. And that becomes a decision based on a lot of factors, right? What is their age? What is their functional status? Just talk to them. A lot of times you can if you're on the fence, you just talk to a patient, and really quickly in a conversation, you can kind of get a feel, this person may be better with a hemi. They're already on a cane or walker. They're in a nursing home. They have some dementia. They have Alzheimer's. A larger head gives you a better chance for stability, versus the total, where the head's going to be smaller. You may use dual mobility or some other type of option, but definitely be concerned, because the other thing that I've noticed, and I'm sure that you may have seen this now, is that it seems that every single time you do a hemi or total for a neck fracture, like, how big is the head? 46, 48. You're lucky if you get a 50 cup in. With certain implant companies, you might get a 36 head. But if you're using, a single, head liner construct, you're looking at like a 32 head for a hip fracture. We're high risk, which is why a lot of people are going to dual mobility. So you get a larger head size in those smaller cups. It's rare to have a neck fracture and put a 58 millimeter cup in. So if you're going to go to a 48 size head, it's sometimes nice to have the unipolar, or if you choose to use bipolars, you can use bipolar, but at least you get a larger head in there for the hemi, versus a 32 for your routine total if you're treating that for hip fracture. So again, Guarding classification, stage 1, 2, 3, 4. 1, again, don't forget, valgus impacted, yes, but incomplete. The inferior neck is still intact. 2 is complete, but non-displaced. 3, complete and partially displaced. 4, complete, fully displaced. And then Pauwels classification, Pauwels 1, 2, 3, a line drawn off the horizontal, and then the angle where that line off the horizontal then comes through the fracture line. Pauwels 1 up to 30 degrees. Pauwels 2, 30 degrees to 50 degrees, and Pauwels 3 is greater than 50 degrees. And again, go ahead, look up Ward's triangle, check that out, just put that in your brain for your armamentarium of hip fracture 101. And then keep listening. If you haven't subscribed, subscribe. Your other co-residents or maybe medical students on service, share this with them. I have a lot more classifications coming up. It's just there's so many classifications, and honestly, not in any particular order of importance. Just trying to pick and choose what to put up there for you. But I have some good ones coming up in the next few weeks. So in the meantime, keep reading, keep studying. Take care of yourself. Take care of your patients. Thanks for listening. I'm Adam Rosen. You've been listening to the Total Knee Tips and Pearls podcast. Until next time, stay safe. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.